Success is not just about luck. It's about persistence, determination, and hard work. Hi, this is Dr. Majida. In this video, I will be sharing some tips and tricks and pearls regarding long case and short cases. So let's get started. This is the list of topics for long cases which I have made from my own experience and some previous exam candidates. Out of which most common is diabetic retinopathy, CRVO, BRVO, retinal detachment, and ARMD. Diabetic retinopathy can be in any form like NPDR, PDR, or advanced diabetic eye disease. It could be a treated eye with laser marks, or it could be a vitreous hemorrhage, and could be PDR in one eye and advanced diabetic eye disease in the other one. It could be also a vitrectomized eye with a silicone oil or a scleral buckle. The list of other topics is given below. You can read each of them. The long cases are not always straightforward. You can have combined pathologies. For example, you can have diabetic retinopathy with nerve palsies, diabetic retinopathy with open-angle glaucoma, proliferated diabetic retinopathy with cataract, CRVO with advanced cupping, CRVO or BRVO with third or sixth nerve palsy, ARMD with glaucoma, decompensated cornea with cataract or glaucoma. So you should be ready for any of such cases. And in your history and examination, you have to be very quick. Short cases are almost similar as of long cases, but just switch between the candidates. But the command is more precise and focused. You have to be very quick in your diagnosis and you have to answer accordingly. These are the books from which I have studied. Out of this, Dr. Saim Khan's book and Tahir notes are must. I have also attended online preparatory courses by Dr. Khakan and Dr. Maham Awais. Dr. Khakan will give you guidelines from an examiner's point of view, while Dr. Maham will give you insight from a candidate's perspective. So I will advise you to attend both of these. Other than this, YouTube videos by Dr. Khakan and Dr. Moin were very helpful. This is the list of the things you should have with you on your exam day. You can take a screenshot so you don't forget it. On the day of exam, you will have your long case first. Enter the examination hall with confidence and smile because today is your big day. Just be yourself. Greet the examiner, greet the patient. Help the patient to walk into the cabin if needed. Organize your examination kit on the table. Keep your torch, scale, extra ocular movement target and occluder in your pocket so it's reachable. Write your name and roll number on the given sheet. The bell rings and the art begins. Yes, history taking is an art. Try to find the clues. Less time, more information. Just give 5 minutes, not more than that. Ask about the presenting complaints and let the patient speak. But if he is giving irrelevant details, then start asking direct questions. It will save your time. At the end of the history of presenting complaints, you should have a provisional diagnosis in your mind. Then ask relevant mandatory questions. Don't forget the history of glasses, trauma, smoking, job, lifestyle, stress, diet, travel, and pets. As you all know the components of history, it's biodata, the patient's info, that is the name, age, residence, profession, student or housewife, marital status. Then presenting complaints, history of presenting complaints, past medical history, which consists of ocular and systemic medical history, past surgical history, again ocular and systemic surgical history, drug history, also ocular and systemic, family history, ocular and systemic, personal history, history of glasses, birth history, especially in case of squint, congenital glaucoma, congenital cataract, etc., history of trauma, and history of travel and pet history. If you have a digital BP app, you can check the blood pressure at the same time when you are asking the patient about his hypertension history. For examination, make two columns, one for right eye and other for the left eye. Start examining the eye with pathology first, but if the problem is bilateral, then start with the right eye. After history taking, take the vitals of the patient and look for general physical examination. In GPE, also look for any facial asymmetry, any signs of trauma. If there is ptosis, proptosis or squint present, you have to do the relevant examination. Also perform cranial nerve examination if you find even a single nerve palsy. Cornea sensations, better to check at this time, or if you like, you can check them on slit lamp also. Then you have to perform the relevant CNS, CBS, chest auscultation and abdominal examination as required. Components of examination. As you all know, start with visual acuity. You can start with finger counting, so you will get an idea of how the vision of the patient is. Is it poor or is it good? So you may know how to proceed. Start with an unaided visual acuity, then with pinhole, and then with glasses if the patient is wearing. You can ask the patient for glasses because sometimes the examiners have kept the glasses with them. So when you ask, they will give you the glasses. For near vision, as the patient is dilated, you have to make him wear plus 2.5 diopter lenses in the trial frame to check the near vision. For color vision, just use green or red bottle caps. No need of Ishihara chart. Pupillary light reflex, use torch with yellow light. Look for RAPD, APD, projection of light and perception of light. Extraocular movements, do the versions only. If there is any restriction, then do the adductions. And don't forget to check the convergence and saccades. Then do the cover and uncover test. Visual fields, you have to perform both central and peripheral by the confrontation method. Amsler grid chart, also with near glasses plus 2.5 diopter in the trial frame. After ocular examination, bring the patient to the slit lamp. Inform the patient about the examination and the light intensity. Clean the chin and headrest with alcohol swab. Adjust the lateral canthus with the mark given on the slit lamp. You may need to check the settings of the slit lamp because sometimes they are changed just to see how you will manage it. Start with adnexa, upper lid eyelashes, lower lid, puncta and do the regurgitation test. Ask the patient to look up. When you do this, just see the conjunctival fornix and also look for any hypopyon at the same time. When you ask the patient to look down, then you should look for the bleb, cornea sutures or incision mark. Then ask the patient to look toward his nose and explore the temporal conjunctiva. They could be hidden tube shunt, scleral Becker or subtenon canalog depot injection. For your ease, make two columns, one for each eye. Write the findings in a sequence of eyelids, conjunctiva, cornea, anterior chamber, iris, lens, vitreous, and retina. Draw the pathology if possible. Always ask the examiner before taking IOP or performing gonioscopy, because sometimes examiner may say that it is normal and then it will save your time. Then you have to perform indirect ophthalmoscopy. One of the reasons most candidates fail is not their lack of knowledge, but lack of time management. I will give you some tips by which you can save your precious time. In history taking, instead of writing complete sentences, you can just write words or letters and cross them if they are not present. For example, if you have to write painless, just write pain and cross it. Similarly, floaters, flashes, redness, you can write it and then cross it. For examination, do the relevant examination first. Don't hesitate to ask the examiner for help while taking visual acuity, because it's better than running toward the chart and the patient. And as I told before, that you can ask the examiner before taking IOP or gonioscopy. Sometime the examiner will tell you that IOP or gonioscopy is normal, so you don't have to perform it and you will move on. It will save your time, especially when the case is not of glaucoma. Just a quick look on few things which you should not miss in each case. For example, family history for glaucoma, duration for diabetes, risk factors for CRVO, BRVO, sun exposure and smoking for ARMD and OSSN, variability for ptosis, smoking for thyroid, history of myopia, cataract surgery, YAG laser and retinal detachment, history of steroids and stress in CSCR, steroids in glaucoma, and history of tuberculosis in uveitis. When you have completed your history and examination in 30 minutes, the next 30 minutes is your viva. The examiner will ask you to present your case. Then he may ask you that on the basis of history, what is your provisional diagnosis and what are your differential diagnoses? What are your positive findings? What is your definitive diagnosis? He may ask you to elaborate your differentials. After a diagnosis is made, he may ask you what is the pathogenesis of the disease. While discussing the treatment options, he may also ask you the mechanism of action of the drugs used. The most common question asked is how you will manage this case. In it, you have to describe in detail the history, examination, investigations, treatment options, medical, surgical, counseling of the patient, and follow-up. While discussing the investigations, the examiner may hand an investigation to you and ask you to explain it. So you should know how to read an OCT, its each layer and its pathology, fundus autofluorescence, FFA, ICG, its phases, its dyes and pathology, cornea topography, type of topography, types of technology used, its quad maps, best fit sphere, and topographic signs indicative of keratoconus, risk assessment for refractive surgery, etc. In visual fields, you should know the types of perimetry, its principle, its interpretation, reliability indices, mean deviation and pattern standard deviation, etc. In OCTA, you should know its principle, interpretation, advantages and disadvantages. And you should also know how to read OCT RNFL, optic nerve head, and B-scan. There are some topics which you should revise a day before your exam. For example, anti-VEGF, its type, structure, molecular weight, and treatment regime. Newer anti-VEGF should also be read. Then immunomodulators, biologicals and biosimilars. You should know how to manage macular edema, types of keratoplasty and its indications, keratoconus treatment options. You should also know lasers like laser PRP, YAG laser capsulotomy, laser PI. Revise squint examination. You should also know fusional reserves, horopter, fusional area of Panam, diplopia test, accommodation convergence accommodation ratio, FDT test, AV patterns, and surgical procedures of squint. And you should also know how to manage posterior capsular tear, what are CTRs, and scleral fixation IOL in detail. There are some tips for short cases. Listen to the examiner's command carefully. Introduce yourself to the patient and inform him about the examination. You can examine first and then describe your findings, or you can keep on describing along with your examination. It's your choice. But sometimes examiner may command you to describe your findings while you are examining. Even if the command is posterior segment, give a quick look at the anterior segment, the state of the lens, and the anterior vitreous. You should know how to use direct ophthalmoscope because in case of keratoconus, the examiner may hand it to you and ask you to see the oil droplet reflex. You should also know to use indirect ophthalmoscope for the cases of retinal detachment. Ask the examiner before inverting the eyelids and also inform the patient about it. Ask the patient for any pain before touching the patient. Check the gross vision of the patient before giving any target. After slit lamp examination, don't forget to switch off the slit light beam and ask the patient to sit back. And most importantly, don't forget to thank the patient after examination. Now it's time for some secret pearls. Yes, if a patient is young, for example in his late teens, the most likely diagnosis is keratoconus or Marfan syndrome. If patient is old in his 80s, he is likely to have ARMD. If patient is undilated, most likely he is going to have an anterior segment pathology or has glaucoma, so you can do gonioscopy. In anterior segment command, don't ignore cataract or a PCO because it could be the only finding and your viva will be on it. I would like to end my presentation on this note that your key to success is your mindset on the day of exam. You should feel like a consultant. You should be confident. You should look professional. You should be humble. Your attitude toward the patient and examiner should be very well. You should know how to manage time, and of course, you have the knowledge and skills to pass this exam. I hope this video will help you in your exams. If you have any questions, please write down in the comments below. Remember me in your prayers. Have a good day and good luck. Thank you so much for listening.